I'll just begin with the recording as well as the live streaming, after which I'll start with a short introduction and then hand over the session to Dr. Yash. So I'm just beginning.
Recording in progress.
Good afternoon and a warm welcome to all the dignitaries present here. I am Asya from Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarnet serves as the digital partner for this event hosted by the Indian Sepsis Forum, and the focus of today's session is Sepsis Conclave 2025. So without further delay, I am pleased to warmly invite Dr. Yash Javeri sir, who is a leading critical care and emergency medicine specialist. He currently serves as the Director of Critical Care Medicine and Emergency Medicine at Regency Super Speciality Hospital, Lucknow. Dr. Javeri holds several esteemed positions, including Vice President of ISCCM, Secretary of the Society of Neurocritical Care, Dean of the Indian College of Emergency Medicine, and Convener of the Indian Sepsis Forum. A past chairman of SCCM Delhi NCR, he is widely recognized for his leadership, clinical excellence, and contributions to advancing critical care and sepsis management in India. Now, I would like Dr. Javeri to officially begin today's session. Over to you, sir.
Thank you, Asya. Thank you, Ritu, and thank you, Mr. Raja Clearnet, for all the support. Today, we have gathered here to mark Sepsis Awareness Month, probably the last day of the month. And the session, what we are going to have is Sepsis Conclave. MAP Sepsis, we have labeled the session. By MAP Sepsis, we want to elucidate on the comprehensive diagnosis of sepsis, the microbiology, the anatomy, and the physiology of sepsis. Microbiology, who is the enemy? Anatomy, where is the enemy? And physiology, what is the damage to the pathophysiological effects of sepsis? APSA has been kind enough. Dr. Ashwani is representing APSA, and Brett has been helping us out for organizing this CME. And Indian Sepsis Forum, me and Dr. Neeraj Tyagi have been representing Indian Sepsis Forum. Dr. Rahul from Anaesthesia TV and Mr. Varun Soneja from Cepheid has been helping us to promote the program. I would like to invite our chairperson, Dr. Ashina Jahalopa. She needs no introduction to the gathering, but I'll still do the honors. She is consultant and in charge Department of ICU and Emergency at ICU Specialized and General Hospital at Dhaka. She is WHO Technical Advisor. She is Secretary Foreign Affairs Society of Intensivists, Bangladesh, and she is a very renowned figure in critical care globally. Over to you, Dr. Lopa. Thanks for joining, everyone.
Thank you so much, Dr. Yash Javeri, for your kind introduction. So it's my great honor to welcome you all to the Sepsis Conclave 2025, organized by the Asia Pacific Sepsis Forum and the Indian Sepsis Alliance and the Indian Sepsis Forum. Today, we have gathered to share knowledge, experience, and innovations on sepsis management, a challenge that unites us all across the globe. We have an excellent lineup of distinguished speakers and panelists who will take us through important topics. So I'm delighted to present the name of our speakers today. So today, Dr. Ratpom Champunat, who is the pulmonary and critical care consultant, Bangkok Hospital, Thailand. Also, we have Dr. S. Shubha, who is the consultant microbiologist and infection control officer, Dr. Rela Institute and Medical Center, Chennai, India. We have also with us Dr. Mahendra Kothawala, who is the consultant clinical hospital of Sri Lanka. So without further delay, let us begin our first session on theory to reality, the sepsis easy models for research limited settings, which will be delivered by Dr. Ratpom Champunat from Thailand. So over to you, sir.
Okay, everyone can see. Okay,
Yes, sir, your slides are visible.
yes, thank you.
We can start, Dr. Ratpam. We can start.
Sir, are you saying something? Because no one is able to hear you.
Yeah, I think Dr. Ratpum, you are not audible. Dr. Ratpum, can you hear us?
Excuse me. The slide is not shared.
Uh, Actually, you are not audible to us. Did you start your presentation? I mean,
Oh, okay. Sorry, the slide is not shared. This slide
yes,
shared.
yes, yeah, yeah. We we can see the slides, but we can't hear you.
Oh,
The slide is
okay.
auto moving. I mean,
You cannot hear me.
now I can hear you. Did
Okay,
you
okay,
start? Okay, yeah, you can start now.
okay.
Yeah.
Okay. Now, good afternoon, esteemed colleagues and distinguished guests. Excuse me, can you hear me? Because I have a very sore throat. Hear me?
Yes, yes,
Yeah.
you are audible,
Okay.
sir.
Okay. Sorry. Good afternoon, everyone. My name is Dr. Ratapum Champunot. I am honored to be here represent Asia Pacific Sepsis Alliance. My specialist is pulmonary and critical care, and my work focus on improving outcome in sepsis, particularly in resort limit setting. Today, I will share our journey in Thailand, taking sepsis management from theory to reality, the sepsis easy model. We are all here because of a common enemy, sepsis. From the global sepsis challenge, sepsis claims alive every 2.8 seconds, and sepsis is a global burden too much. A life is lost to this condition too much. Why 19 million people survive annually? Many face lifelong complications. In my own country, Thailand, this global, we face approximately 125,000 cases every year, and we have too much death. We estimate that every 3 minutes septic patient in Thailand occur, and every 1 hour septic patient die 5 cases. This shows that we have the implementation gap. Now that you can see from this slide, we have a guidelines serving sepsis campaign from 2004 and now 2021. Why? What is happened? We have evidence-based guideline, but real challenge is implementation gap, because how can we use this to implement and to treat our patient? So first, in my opinion, to bridge this gap, we must understand our local context, our epidemiology, our resource setting, our team and network, and our patient state of sepsis. In Thailand, for example, we found over 80% of sepsis is community-acquired sepsis, not hospital-acquired. So this single factor shape our strategy, force us to focus on the network and emergency department and pre-hospital setting to our hospital. And another thing, this healthcare system, this challenge exists across various healthcare structures. In resource limited setting, the primary level healthcare, the secondary level, and the tertiary level, we have a limited resource in each setting. And who use sepsis guideline? Because this is the big problem that we can save the world alone. If you are professional, you can take care the septic patient 24 hours. You should have a team, and the real world frontline in hospital is a young staff. This is the real thing. So the reality of our frontline team is immense pressure. They face overcrowded patients, limit diagnosis resource, overriding complex protocol, and high staff turnover. This is the environment where implementation fails. So our guiding philosophy, this leads us to a powerful, simple idea. We have to simplify everything. We shift our focus from creating the perfect protocol to creating the most practical one. Our guiding philosophy became the best protocol is the one that gets used. The sepsis easy models built on 3 core pillars. First is simple and early recognition. Use easy screening tools that are quick and accessible. The second pillar is action ready to bundle or protocol that ready to use, and the pack of instruments that you can use easily. And the third pillar is network and empowerment, training your network and use protocol for every setting to build the structure of sepsis care in your network. The first pillar, sepsis easy screening tool. For recognition, we create a simple nurse diary checklist. It uses only basic vital signs, requires no initial complex lab, and has a clear action point to activate the protocol. This empowers nurse to identify sepsis early without waiting a physician. Why tools like SIR, News, Muse, or SOFA is too complicated? In Thailand, first we use the early warning score that we modify in our country and use this tool. Is a SOS score. SOS score is a search out severity score, and that modify to our patient that on ventilator or on vasopressor, and we add urine monitor when the SOS score more than 2, more than or equal to. You should monitor urine to your patient too, but not insert the folate cat, just only monitor. If the SOS more than 4, sometimes we insert the folate cat to monitor this, because we monitor tissue perfusion by urine actually. And after the score come, we should do this. What to do next? A high score of over 3 immediately trigger physician notification and intensive monitor every 30 minutes. This answer that what to do next. And this show that how everyone who come to the hospital should monitor with SOS, because SOS come from vital sign. This is a modified early warning score that used. And the pillar 2 is a sepsis protocol. For our second pillar, action ready 2, we embrace cookbook medicine. We simplify the surviving sepsis campaign bundle into the standard, easy to follow resuscitate protocol for community hospital and emergency department. We have launched it from 2006. This includes taking culture, give antibiotic, and administering fluid and vasopressor in the structured way. This is our early protocol in the past that now we research and develop until now. This is a checklist that we divide in T part: early detection, early resuscitation, and how to monitor and record. And this is why we use the protocol, because the key factor to improve clinical outcome is competency of clinical response. When you early detection and you have time to treatment with patient, the competency of clinical response can collect by the checklist or protocol. And the third pillar is empower to network. This is the most critical, because we focus on our network that will face our patient with septic shock in the front line. This, you can see, this is our setting, resource setting specific, that community health station that don't have doctor, just only nurse and healthcare worker. And the community hospital, we have just only 5 or to 10 doctors in that hospital. And the provincial hospital, this is a larger hospital, and the referral center. So as that I tell you, resource setting specific guideline is the best way that you can cooperate together. So we do this community health station. What do you do? What you can do? Early recognition, use just only early warning score, SOS score. Early resuscitation, you give just only IV fluid and oxygen, and monitor the oxygenation by SpO2. And early refer this patient if the score more than 3, and refer to the community hospital, and the community hospital give antibiotic IV, because in the community health station we don't have IV antibiotic, and the community hospital resuscitate with easy bundle. Don't insert the central line, just peripheral line to give the more fluid, and start vasopressor with the protocol. Dilute it too much before you insert in peripheral. If you use the norepinephrine, you should dilute as protocol direct, and then refer to the provincial hospital and referral center to monitor in acute phase in the ICU or in the area that have too much nurse to close monitor this patient in acute phase. And then after 2 days or 3 days after resuscitate early, the patient can then refer back to the community hospital and give IV antibiotic further until it's a success. This is our guideline that I will show that we have a separate in the resource setting guideline and co together. This is the protocol that we make together, and this is our network that we cooperate. We go to many hospitals in our community hospital to share our experience and tell that what you do and cooperate together when should you refer this patient to our hospital. And then this is the result from that period that we do from in the past, that the high mortality. We implement CPG, maintain CPG, we have a campaign, we have the fast tag, we have a rule of three that's just like sick bundle. We have a early warning score, and now we implement corporate sepsis management protocol together. And we share that this community acquired sepsis, you should do this early detection, maintenance, and monitor. And hospital acquired sepsis, that is about less than 20% of our septic patient. You should do in your hospital. Do this. Prevention is good. IC infection control is good. But if you can early detection by the early warning score. And after that, after success, we space change from our region to the 12 healthcare region and 77 provinces in Thailand. This is our sepsis network in Thailand. We have too many people that cooperate together in each province, and we create a Tri-Sepsis website, like group sepsis nurse, and we have a community of practice sepsis, and we make a handbook for health volunteer in Thailand. And we set the World Sepsis Day Thailand every year to share together and meet and set the activity together. And this is our region that we do together, that we fight against sepsis from 2006, from the first Thai guideline, and then we set the fast tag, ICU fast tag, and network that work too much, simplify it, sepsis 6 bundle, and implement the early warning score, SOS score, from 2009 to early detect sepsis, and initiate sepsis website, and set the conference for World Sepsis Day, and set a campaign together in Thailand to save life. And we have the Thai Sepsis Alliance that established from the many society and healthcare organization. And we have the Global Sepsis Award together in 2016. And sepsis is one of the healthcare policy in Thailand from 2016. Sepsis is one of the main health policy in Thailand, and we have the committee to monitor and take care about this. And I would like to show this from the clinical practice guideline. You should planning and define it to protocol and implement it, and you will have a new technology or new idea to improve your clinical practice guideline and protocol. And from this T-delay model of sepsis that can cure our patient, we collect with this early detection by early warning score, SOS score, and use sepsis bundle or EC protocol for early resuscitate. And after that, monitor in the ICU, or if you don't have ICU, use the rapid response team or rapid response system, and use network together. And from that, I tell you, we use 6 building block platform WHO to create the structure that you can see that what is the important thing to create the sepsis management. And from Thailand, we have a key lesson for adaptation. That the first is, in my opinion, start simple. Don't try to change everything at once. Second is empower your nurse and your team and your network. They are your most valuable assets in the early recognition and early resuscitation. And the third is adapt, don't copy. Copy and development, modify to fit your local workforce and resource. This is the implementation success factor, that leadership buy-in, multidisciplinary team, continuous refinement, and data monitoring. I wish that a new reality is possible. The gap between theory and reality can be closed, and the solution lies in simplicity, practical tool, and empower our people. The Sepsis Easy model offers a proven, adaptable pathway to save life. Thank you so much. If you would like to learn more, you can go to the www.sepsiseasy.com. And if you have question or some discussion, please. Thank you so much.
Thank you so much, Dr. Am I audible?
Yeah.
Okay. So thank you so much, Dr. Ratpum, for your wonderful talk. So,
Yes, thank you.
So let's move on to our next speaker,
Yes.
Dr. S. Subha. She will talk on role of CRE screening in sepsis management. So welcome, Dr. Subha.
Yes, thank you for the kind introduction, and I'm very privileged and honored to be amidst this forum, and this is the first time I'm with this forum. And thank Dr. Yes sir for this opportunity. And I would be sharing a little of our experience that we had with this topic on role of CRE screening in sepsis management. And yeah, I've made it full screen. I just want to make sure it is. Yeah. Okay. The overview of this topic will be touching a little on the burden of CRE globally, its significance, and what are the methodologies in CRE screening, infection control precautions after any screening or testing for CRE, and at-risk population at the level of CRE screening, and a very short note on treatment, outcome from our own study findings, and few concluding points. And the majority of my discussion today will be from this article. This is the publication by our own team, the intensive care team. And I was a very small part, in fact, just helping in the testing. But it's the test that gave all the meaning. And we have a lot of insight after this work. Although it was retrospective, that might be the limitation of this work. It was close to 3.5 years consolidation of findings, and we could relate a lot of our findings, and there were interventions which was done parallelly to this. So this is about the outcomes of living donor liver transplantation recipients colonized with carbapenem-resistant enterobacteriales. So the burden of CRE has been very beautifully told and more powerful statement, which says about by 2050, the death from antimicrobial resistant infection is estimated to surpass that of, say, measles, road accidents, and cancer in combination, to show the burden of antimicrobial resistance infections. And this can happen in millions, the 10 millions by 2015 across the world. And if we look at the volume or the death attributable to antimicrobial resistance every year by 2050 in different countries, we again see Asia is topping the list. So representing from the same, it's also important to emphasize that WHO also has put in under their priority pathogens list where carbapenem resistant enterobacterales is there in the critical or the priority 1 pathogens. And the problematic pathogens that we famously know of as escape includes Klebsiella species and E. coli, which is the predominant 2 organisms under CRE. This is one a decade back, a picture of the burden of CRE across the globe, which is almost the same. I didn't get a better picture to say if the volume has increased. It's indeed a little worrying that India still rates the highest when it comes to carbapenem resistant enterobacterales, where it takes the volume of 50 to 60% of CRE across the globe. So we have to be more prepared, more proactive, and more sensitive to such infections when it happens to our patients. So what can we do more and how careful can we be? And coming from a liver transplant center, one of the highest volume across the world, we are bestowed with the best practices and what more to be done in order to be careful to care for those immunosuppressed patients. So in the same lines, would like to take this important aspect across being carbapenem resistant enterobacterales. Let's understand that this is not always due to the enzyme production. It is also due to non-enzymatic mechanisms such as hyperexpression of multiple beta-lactamases, porin losses, and efflux. So when there is efflux mechanism, the drug is thrown out, the carbapenems are thrown out, and because of porin loss, the drug cannot enter. And these beta-lactamases will cleave the drug. So it is because of this that carbapenems don't work. So 90% of the CREs are due to carbapenemases when it comes to Indian data. From the British Society, it is about 50% from the statistics. So this is very important for us to understand that when a huge volume of CRE is due to carbapenemases, it would be ideal to look for tests that will detect the genes responsible for these carbapenemases. And when we do in one shot, in a relatively lesser turnaround time for any suspected gram-negative sepsis, I think we can act much earlier, and enough data is there with every hour of faster diagnostics. We save a patient who is in sepsis from morbidity by about 8% for every 1 hour. All of you would agree to that. And when it comes to identifying, someone is not privileged enough to be in a center with molecular diagnostics, and all you have is only a susceptibility report, and how am I to pick up a CRA from a culture report? Yes, it still can be done. Carbapenemases to contribute as CRE, we would mostly see this kind of spectrum where all the 3 carbapenems will be resistant. Sometimes the imipenem will show sensitive or intermediate, but miro and eta will show resistant. This kind of combination is usually NDM MBLs that we have seen in India. Non-carbapenemases, that is only the 10% strains, will have imipenem, meropenem sensitive or intermediate, but eta will be resistant. Again, this percentage, please, let's remember, it's just the 10%. And imipenem, if you see subsequently the same strains, might also change or acquire genes, or rather start expressing the inherent genes also, which is transferred. Either ways, it is acquired. So imipenem resistant, but mero and say ceftazidime sensitive, it could be an OPRD or a OXA mechanism. So this is what can go into a CRE. So if we remember this pattern, in the event of non-availability of molecular tests, we can still identify a potential CRE or know the mechanism and give appropriate combination of drugs for effective therapy. So when it comes to mild expression of MBLs, higher MICs for all the 3 can be seen, but the sensitive range, it will be still within the sensitive range. So these are the subtle things that we'll have to pick up. And there is seldom one single enzyme mechanism which is involved. But detecting is complex, although it's not impossible. It can be done with all the available modalities right now. So what is the significance of CRE screening or testing? So why detection of CRE is important? We just noted that it is notorious for their diverse and extensive antibiotic resistant patterns, resulting in significant morbidity and mortality. They have become a serious global health concern in the last decade, and this issue has reached concerning proportions in developing countries like India due to several reasons, including rampant use of high-end potent antimicrobials. So why detection of CRE is important? To establish a therapeutic strategy. So I find in OXA48, my immediate mechanism of therapy would be, say, ceftazidime avibactam, and if at all NDM is along, aztreonam might have to be added. So this kind of clear indication of what to go next can be given with the help of this CRE gene identifications. So the system that we use in-house is the Expert Karma, and it is used actively to monitor at-risk patients, such as those who have been transferred from one country to another. This kind of population is what we get to see most of the times. And they would also be referred from other hospitals, so between acute care or long-term facilities. And these individuals are most often at risk of infection, given the fact that they are part of a transplantation recipient who would be on immunosuppressants in order to prevent graft rejections, having undergone the recent surgery and in the ICU, immunocompromised, might be on dialysis, which implies that there could be an acute kidney injury or a chronic renal failure. So for all this, the person is at risk. So those who have previously been identified as CRE carriers are also individuals who are at risk. So the same system, when performed on rectal and rectal swab specimen, helps to quickly identify, which gives us as actionable information. I just told you about the two genes and the possible therapeutic option, and it immediately gives us the best patient management and design effective infection control measures. In one of this critical care journal, where identification and infection control pathway has beautifully told, and it still stands good, 4 years back article, which says preemptive contact precautions for surveillance can be done. And when CRE is found to be positive, contact isolation precautions or cohorting, if we are unable to get a single room, it can be definitely, the patient can be cohorted in the same unit, the positive individuals with necessary barricades and precautions. I'll just elaborate a few of them. If negative, to stop the isolation and the standard precautions and regular surveillance to be done. So this can be done on a regular basis or a weekly basis in order to see if the patient is in the ICU for a longer time, to just see if there is a CRE acquisition by any chance. And 3 sequential results, as per this article, will say negative, but we have a different school of thought for that. So a quick run through of the infection control precautions after screening and testing. Say, for example, we have this one particular individual who is CRE positive. We make sure that we display on the dose sign as a dose sign onto the isolation unit, and make sure that it is bilingual. Having educated the immediate caring nursing team and the treating doctors, even the housekeeping staff would be informed prior, and they would already recognize this kind of, say, yellow display is meant for contact precautions. What does that mean? That they have to have clean hands with standard, hand hygiene practices. Make sure they enter for any particular handling of patient care procedure with gloves and gown, and has to be removed before going into the next patient or next unit, and dedicated patient handling equipment such as stethoscope or BP apparatus, and the patient has to move across the unit with prior information to the receiving unit. So this will always be in bilingual with the local language, so that if even the housekeeping staff will get to understand what is written and what they're expected to follow. If they are new individuals, they just re-emphasizes beyond the education that is imparted to them. So this is also to specify the type of precautions and no breach in confidentiality of the patient. This is a general contact precautions. No, we do not claim that this patient is CRE, because the same hold good. Even say, for example, a person is on, MRSA, there would be another, AMC producer. So this is a general, disclaimer on the door to take appropriate enhanced contact precautions. So there is no breach in confidentiality of the patients. There is no announcing. So other best practices are from the guidelines of HICPAC, which would emphasize on the cleaning requirements, which is very, very important for CRE, either colonized or infected individuals. And we also take points, being a predominant surgical unit, of the requirements that is meant to prevent SSI, and this patient being in an ICU, the requirements that the patient's placement in an ICU as per ASHRAE. This is a picture from our own unit to also have touchless technologies, which will help in one step of better precautions where there's no handling of these taps or the hand hygiene dispenser, hand rub dispenser. This we had used rovers, which was customized. I thought it is very good to share during COVID time, where less contact with the patient in the event of or the visitors to that of a critical care patient. So the movement is reduced. So the chances of visitors carrying these organisms in any way is not coming in contact with the patient. So this is nothing but an iPad put onto an the injection stand, and it is moved accordingly so that we can still talk to the patient, and but there is no direct contact. So this is one of the very good innovative indigenous infection control practice that just came up. Many of them had used during that time. So technologies to improve the cleaning monitoring, we kind of also evaluated the effective utilization of an ATP bioluminescence and fluorescence marker to see the efficiency of cleaning among the healthcare, housekeeping staff, in order to motivate them if it has to be done even better. So this ATP levels will represent the organic load that is present and the general cleanliness of the surface. All what is done as swab would be done and put onto this particular machine to get a relative light units that will tell about the bioburden that is there in that particular area. We can also put fluorescent gel markers into various environmental surfaces and see if it has been cleaned properly, where you have to put a torch after the cleaning is over to see whether it fluoresces as yet. So this will assess the housekeeping practices. This is standardized by our own infection control nurses. And we can also educate our healthcare individuals to do appropriate hand hygiene movements in order to see if they know how it has to be done. So if it is not done properly, then the whole exercise is of no use. So make them do a glow germ and see if they have tried it well and they know how it has to be done. So all the more important beyond all this is to not replace cultural measures such as healthcare teams education, re-emphasize that this is a CRE patient and how important that contact isolation precautions is, and the establishment and complaints to protocols, multidisciplinary visits where the need for devices and mechanical ventilation is questioned, where more than 5 important points of standard precautions carry for, again, contact precautions. All of us know very well, and let's adhere to it. Besides, a sterile instrument is equally important in order to prevent any transmission of infection from one to another. So rest all is the same. So aseptic technique and handling of the injections is important. A very spacious ICU and demarcation of unit from one to another is equally important. They should not be cramped. So that was our own ICU unit. So the Indian Society of Critical Care Medicine Experts Committee has given or come up with a consensus statement on the ICU planning and designing in 2020 and still holds good and perfect. So the recommendations of the State Pollution Control Board also takes care of the biomedical waste guidelines that has to be followed in letter as well as in spirit. And each bed must have a 24/7 hand rub solution and the elbow-operated water tap for at least 5 beds. And all linen and equipment used in the ICU procedure should be sterilized, disinfected by standard methods. I'm just running through rest of it. So we know how important the single accommodation cubicles when it comes to contact isolation precautions. It is neutral or pressure rooms is more than suffice, and adequate spacing between the beds if in case we plan to cohort without choice. And there should always be an extra space in order to prevent any cramp. This is to accommodate the nursing station, storage, patient, doctor, staff, movement, equipment. So this is also again same emphasized by Indian Journal of Respiratory Care with respect to the nurse staff, patient and nurse staffing ratio. When it comes to liver transplant ICU, it is 1:1, and indicators of all the bundle cares has to be documented, and compliance has to be done in every other shift check. So, and access control in order to restrict people movement so that it becomes easy in one go. We don't have to, keep emphasizing. So this is our own entrance liver ICU at our institute. So I have a quick question. Maybe we won't have time for your, replies, but you can just try answering. How long should patients with MDRO, in our case it is the CRE, be placed on contact isolation in the facility? So how long? In one of the journal, just we discussed that it says 3 negative cultures. Yeah, I have someone in the chat box answering, but anyway, yeah, I'll go for the answer. We follow or make sure that the contact isolation precautions will go as long as the patient remains in the facility. Okay, the reason is the patient is on antibiotics, which means the patient we know is suffering from some infection, and then there are drains, and then there are lines, and the patient's running temperature. In all such conditions, HICPAC tells us it's better to keep the contact isolation precautions. We don't know if there is inadequate removal of the colonization. So it's important with respect to CRE is not just the infection is to have under contact isolation precautions, even the colonization. So why detection of CRE colonization is important? I'm now coming back quickly into our study findings. So our study, our population being the liver transplant recipients, there was an active pre-transplant surveillance done for these recipients, and along with the use of targeted preemptive therapy of probiotics and a very low threshold for discretionary use of appropriate guideline-based antibiotic therapy based on the CRE colonization status. So how did we do this? Okay, yeah, this is just for the completion. Let's understand that the incidence of, say, CPE is carbapenem is producing Enterobacteriaceae, and CRE is carbapenem-resistant Enterobacteriaceae, or rather Enterobacteriales, going by the newer nomenclature. So a few statistics is in liver transplant, it is close to 6% coming to incidence, and ours is around 5.2%, which is going in line with the lower range of expected incidence across the globe. When it is along with lung, it could be, say, 8 or 24 if it is a repeat liver transplant. For this very reason, the cohort of group that we took for the 3 years will be without any repeat transplant, so that we don't have a higher numbers unduly taking a different population or a combined solid organ transplant recipient. So they were under exclusion. So for the 3 years, close to 3 years plus, it was about 499 liver transplant recipients who came into the cohort of our population. So quickly about the perineal swab, not too far away from the neighborhood. These swabs, 2 of them are used to collect samples, and more importantly, just before the transplantation, a week before, or say if the patient is getting admitted 2 days before, it is that time that the swab is collected for CRE testing. So among the diagnostic stewardship, we always look for likelihood ratio. That is how high sensitive and high specificity that is important in order to get what we want. And we chose, say, Carba-R, CB-NAT, Cepheid. And this was a gradual shift. For part of a study close to 1.5 years, we were doing a conventional methodology, which was meant for KPC detection and NDM and OXA on the other side. So this is Chrome ID Carbaspar. Slowly we shifted on to expert Carba R, because by that time there was enough evidence to say that it was 96% better when compared to that of use of culture-based screening. For many reasons, there might not be enough growth. And we might not be able to detect all possible genes that will be expressed in 5 of these families. So this is what the literature says. And so we adopted the molecular technology. So what do we call as rapid? Seconds, minutes, hours, days, or months. It's a relative term. Here we shifted what was into hours into minutes. And we tried to give a report, information and support and a guide to what antibiotic to be given. And that was about the clinical microbiology significance, where right test for this right patient at the right time in order to optimize the clinical care. So this particular molecular test will detect about 91 resistant genes within 5 gene families, which includes KPC, not so common in our Indian population, more in the West. And NDM is more associated with E. coli, OXA48 more associated with CLEB, along with class B genes such as WIM-IM, very, very less in our population. So these represent the carbapinamases most commonly associated globally. So coming to the risk factors, I've put from our own study to give the best findings that we have got. It's already known that patients undergoing liver transplantation are at increased risk of such infections due to high likelihood of previous colonization because of hospital admission or prior repeated antibiotics. I have a couple of case snippets. I just want to check I have time. I'll be trying to finish another 5 minutes. So on day 4 of a post-operative LD-LT recipient patient in LT ICU, 2 sets of blood cultures were collected on clinical suspicion of sepsis. So this is a hypothetical case scenario. Imagine with a clinical suspicion of sepsis, the team has already started appropriate escalation of antibiotics because of positive CRE colonization status prior to transplant when evidence of sepsis sets in. Let's remember that we would, with appropriate therapy, we try to reduce the mortality by 8%. So here on day 4, the sample was collected within 10 hours, time to positivity of 10 hours, blood culture flags positive, and the microbiology staffs would inform the critical alert as gram-negative bacilli to the intensive care team. So intensive is requested for BCID, where the positive broth can immediately be put onto another molecular test, which will give us the identification and susceptibility. This is what we have done. So I just took one of that hypothetical element into this case. So backdrop here, let's remember CRE colonization pre-transplant was positive. So same situation, scenario 2, where appropriate escalation might not happen. Now that the patient is already, say, on carbapina, the team is waiting for BCID to tell the answer. So the answer here came in both the scenarios where Enterobacteriales group, Klebsiella pneumoniae was identified, and it also gives us that OXA48 is detected. So when OXA48 is there, by default, the lower beta-lactamases will also be picked up, that is CTXM. So this goes without saying that it is a CPE, that is carbapinamases producing Enterobacteriales. So we get the immediate line of management that is to be given. So this happened on, say, day 5 of the scenario in the situation 2. But in situation 1, because the patient was already having OXA48 in the pre-transplant, by 1 day, there was a savior in giving the right antibiotics. So that's the hallmark of this particular presentation. So subsequently, where in the, say, day 5 of the patient's or day 2 of the sepsis episode, where we get full identification from culture confirmed, and then we have ceftazidime avibactam, MIC sensitive, colistin susceptible, although our guidelines would only ask us to release as intermediate. So this is as per CLSI. So carbapenem resistant Enterobacteriales goes by the definition of ertapenem having MIC greater than or equal to 2, and other carbapenems about 4. So quickly, we know that it's in India, we have this spectrum of E. coli and Kleb, and carbapenemases are more, and we know about the other resistant mechanisms. And this last scenario on day 4, post-operative LDLT, wherein intensivists from the colonies also would request for a CRE detection if at all it was negative, where we also can get from the same system as OXA48 detected and the rest becoming non-detected will also give us a definitive therapy. Again, a slight shift here. If you look back at the case prior to the surgery, it might have not been detected. How can this happen? Points for consideration is negative test still can be resistant to carbapenems due to non-enzymatic mechanisms. And presence of a gene does not imply organism is carbapenem resistant owing to low level of expression of resistant gene. So quickly, this is our finding. In those who had resistant carbapenem prior to transplant, only 15 of them were bacteremic, where some who had not had CRE pre-transplant but also had become bacteremic with carbapenemasis. This is also possible. We know the difference between colonization versus infection, and we know the volume, we know the classification of the carbapenemasis, and we know what spectrum we are getting. Yeah, I'm finishing in a minute now. So we know that there are poor outcomes with colonization, and in our study we found that MEL score and AKI are the preoperative CRE colonizing risk factors, and we also saw that there were intraoperative factors such as blood transfusions in high numbers and chest infections, longer stay patients were all the risk factors for CRE. And relatively, the bacteremia episodes were lesser compared to other studies, possible infection control precautions, and effective appropriate antibiotic therapy early. So this is about when it comes to mortality. In case of higher 90-day mortality was seen in CRE bacteremia cases. And with respect to therapeutic options, there are newer agents against carbapenem-resistant Enterobacteriaceae. In selected cases might not be available in India, such as cefiderocol, plasmomycin, ervamycin, promising ones in the West yet to be in India. So we have all of this in the pipeline, and we know 1/3 of them are colonized. So outcome can be improvised with appropriate infection control precautions and identification with screening. Thank you for the patient listening. And yeah, sorry if I've taken extra time.
So many thanks. Many thanks to Dr. Suva for sharing her experience and knowledge with us. So let's continue our session with our third presenter, Dr. Mahin Kothalawala. He's going to talk on the sepsis mimic, addressing diagnostic uncertainty in early sepsis management. So over to you, Dr. Mahin.
Now we are going to play the video because it's Asya. Please play the video.
Who?
Yeah, please play the video. Dr. Mahin, you can just say hello to everyone, then we'll play the video.
Hi, I'm Mahin from Sri Lanka. So
Yeah.
I'm in the transit, so therefore I won't be able
No problem.
to speak live. So that I have given the
Yeah,
recording in advance.
We will
And-
will play the recordings. Drive safe. Drive safe. Thank you.
Right.
Please play the recording, Asya. Meanwhile, they are putting the recording. We can take questions for the first. Asa, are you playing the
Yes,
recording?
ma'am. Yes, sir. Yes, sir. I'm
Okay.
hearing. Please let me know.
Yeah, you play the recording now.
Yeah, sure, sir. I'm doing
Yeah.
that. Just a minute.
Thank you, Dr. Subha. It was a very wonderful talk. You elaborated on the need for CRE screening, the outcomes, how do the outcomes change if CRE screening is not done in time. So what I see is for transplant, specifically liver or HSCT, screening is not an option for CRE now. It's a necessity and we must be doing it. Most of the time, especially for transplant setting and neutropenic host, we add the options for carbapenem. This is little late, and even hours to days of delay proves lethal for those patients. So I think we are very, very justified in making it as a protocol for CRE screening.
Agreed.
Any other comment,
I
Dr.
need to
Dasrona?
share
Yeah,
Dr. Mahin's slide,
yeah,
right?
yeah, yeah, yeah.
Yeah.
Video,
Okay.
video.
Yeah, the video. I get it. Please let me know whether it is visible.
Yeah. Yes.
Good day to you, my dear viewers. Greetings from Sri Lanka and Sri Lanka Sepsis Alliance. My topic today is the sepsis miming, addressing the diagnostic uncertainty in early sepsis management. So here is how I'm going to present my talk today. Let's start with sepsis. We all know sepsis is a time-critical condition. So that itself says where with every hour's delays in initiating appropriate treatment, it increases the odds of death by approximately 8%. So any delays leads to catastrophic outcome. As you can clearly see with this diagram, if there's any delay in initiating antibiotics, the probability of survival will drop. At 0 hours, time 0, 80% survival rate is there. But with every hour's delay, the probability of survival drops. At 6 hours of delay, the survival probability drops from 80% to 40%. And in 36 hours, the probability of survival almost touches the 0. So therefore, in sepsis, time is life, and you have to start antibiotics, appropriate antibiotics, in the earliest possible time within few hours. When you take the definition of sepsis, it has 3 components. So that is life-threatening organ dysfunction and caused by dysregulated host response or the immune response secondary to infection. For you to identify sepsis, all 3 components has to be there. So that is why I have marked sepsis right at the place where all 3 circles intersects. Mere presence of 2 components is not adequate to define sepsis. So sometimes you can have 2 things but share same symptoms, but they are not due to sepsis. For example, infection can lead to dysregulated host response, as we have seen in COVID, Miss C and Miss A. So that is the symptoms. Although they are similar, it does not constitute sepsis. Again, infection can lead to life-threatening organ damage, as in myocarditis or poliomyelitis, where the infectious agent directly damages the organ. But that does not form sepsis because of the fact there is no dysregulated immune response involved. And at the same time, sometimes dysregulated host response for some cause can lead to life-threatening organ dysfunction. Again, it does not constitute sepsis because it does not appear secondary to sepsis. So therefore, it is very important to understand if you were to call or diagnose sepsis, all 3 components has to be there in your patient. But when it comes to pediatric sepsis and maternal sepsis, the definitions are slightly different. Apart from their physiological changes, the basic definition will have some changes, especially in maternal sepsis. It excludes dysregulated host response because pregnancy is due to part of immune dysregulation, because associated pregnancy itself is a immune dysregulation, because the fetus is kept inside the body by a certain degree of immune dysregulation. And when it comes to maternal sepsis, pediatric sepsis, it is all three components are there, but the trigger is infection or probable infection. So therefore, when you're defining different sepsis in different groups, so you have to understand that sometimes the definition may change. So now let's look at sepsis continuum and inflammatory continuum. Infection, sepsis, and septic shock appear as a continuum of worsening systemic response to pathogen. So they are not discrete entities. So they are parts of a continuum. So you won't be able to definitely identify infection, disease, sepsis, and septic shock separately. So they merge with each other. So that is why we call it a part of a continuum. Infection, sepsis, and septic shock, although they are separate terms are there, so they are very difficult to identify each from each other, because there is no distinct boundaries in defining. Infection, sepsis, and septic shock all are part of a continuum. Only a small subset of patients with infection progress to sepsis. So you can clearly see from this diagram, not all having infection end up in sepsis or septic shock. So that is why we define sepsis as one of the uncommon complications of infection. Inflammation, similar to sepsis, operates on a continuum from localized, well-controlled to acute response to a systemic condition, or it can be a chronic condition. And most importantly, the distinctive factor which differentiates it from sepsis is the trigger. Sepsis is triggered by infection, and inflammation is triggered by most of other triggers, and it also can be triggered with infection. So it is a bit of a complex scenario when we discuss the pathogenesis of inflammation and sepsis. Here is the inflammatory continuum. As sepsis continuum, again, you won't be able to distinctively identify each component. So the localized, well-controlled inflammation and systemic inflammation, so there are no clear margins to identify. That is why we keep them on a continuum. And then systemic inflammation, and when it occurs for a long time, it can lead to chronic inflammation and lead to fibrosis. So this is a very complex pathological process, but we have to understand that these are part of a continuum where the immune system, complement system, as well as coagulation system play a central role in pathogenesis. Inflammation can be triggered by various stimuli, not exclusively by infection. So there are many stimuli, and infection is one of the things. But when it comes to sepsis, it has to be triggered by infection. The symptoms of sepsis and systemic inflammation are often indistinguishable, even though the underlying triggers can be different. So the triggers are different, but the symptoms are same. because of the fact that both sepsis and inflammation shares similar inflammatory mediators and cells. So now let's look at the pathogenic mechanisms. This diagram shows how the pathogenic mechanism interact with each other, inflammation and sepsis. First, we'll take sepsis. As we all know, sepsis is secondary to infection. In fact, there are many infectious agents, viruses, bacteria, parasites, and fungi. And these produces entities which is known as pathogenic associated molecular patterns. It can be lipopolysaccharides, peptidoglycan on bacterial cell wall, and flagellins, the part of proteins made of flagella, and bacterial DNA, and etc. And these constitute pathogenic molecules, which is known as pathogen-associated molecular patterns. So these molecular patterns were identified by special recognition molecules or receptors which are there in immune cells. We call them pattern recognition receptors. So these pattern recognition molecules or pattern recognition receptors, so they identify pathogen associated molecular pattern and brings about changes within the immune cells, which leads to immune response. If the immune response is adequate and the insult is cleared and the patient will be recovered. But if the insult is overwhelming, it leads to dysregulated immune response. We know sepsis has two types of immune responses, two phases of immune responses: initial hyperinflammatory and later immune suppression, which can occur as a separate or at the same time. And when it dysregulated, it cannot be controlled by the body, which leading to organ dysfunction, organ failure, and death. When this dysregulated immune response causes organ failure and death, that is how the sepsis is bring about. In contrastingly, inflammation is brought by injury as well as infection. So the injury, it can lead to production of special type of molecular patterns, which is similar to pathogen-associated molecular patterns. We call them damage-associated molecular patterns. Again, so there are special group of pattern recognition receptors in immune cells, which can detect these damage-associated molecular patterns. It can be HSP, S100, ATP, uric acids, or many other molecules which functions as damage-associated molecular patterns. They will be recognized by the pattern recognition receptors in the immune cells. Again, it brings about the immune response. The immune response is adequate. The host can overcome the initial insult. And if the immune response is overwhelming, it leads to dysregulation, organ dysfunction, and death. So this path, which starts from injury, damage-associated molecular patterns, dysregulated immune response, organ failure, and death, it is brought about by severe sterile inflammation. So as you can see from this diagram, sepsis and severe inflammation both shares similar molecular mechanisms downstream. So therefore, the symptoms has to be same in both inflammation and sepsis. Both pathways converge on same immune cells and can lead to same devastating outcome. These shared pathways highlight why the clinical signs of severe sterile inflammation can sometimes mimic sepsis. Both share common powerful inflammatory engine despite having different initial triggers. So this is one of the most tragic things in critical care. Sometimes patient comes with severe sterile inflammation, but most clinicians misdiagnose it as sepsis and totally ignore the possibility of severe sterile inflammation in those patients. And that would lead to wrong decisions when it comes to patient management. So this need to be understood and followed always, and not to think only on sepsis, but you have to think the possibilities as well. Because all these mechanisms, the pathogenic mechanisms, are mediated by body's systems like immune system, complement system, and coagulation system, both pro-inflammatory, pro-coagulation and anticoagulation system. All these three systems are operating when it generates severe sterile inflammation and sepsis. So the symptoms will be same in both conditions. So you can see clearly there are certain inflammatory mediators and molecules which is common to severe inflammation. Some are shared only with sepsis, and there are molecules which shares by both inflammation and sepsis. Because of both pathways share similar inflammatory mediators, the symptoms of sepsis and severe sterile inflammation are often clinically indistinguishable. So that part need to be kept in our mind, as I told earlier. Consequently, these sterile conditions can mimic sepsis even though they are not triggered by infection. The term sepsis mimics is used to identify non-infectious conditions that clinically resemble sepsis. Critical care units, the doctors in the OPDs and first responders have to understand that severe sterile inflammation sometimes can mimic sepsis. So therefore, always suspect when you encounter a patient who is coming with signs and symptoms of sepsis, because there's a possibility that severe inflammation also presenting with similar symptoms. So now let's look at common sepsis mimic. I have listed several sepsis mimics in this slide to show you that not only sepsis, but there are many other conditions which can present with similar symptoms. So there are autoimmune hyperinflammatory conditions as in hemophagocytic lymphohistiocytosis, Still's disease, systemic lupus erythematosus flares, catastrophic antiphospholipid syndrome, systemic vasculitis. So there are many cardiopulmonary conditions like massive myocardial infarctions, massive pulmonary embolism, acute decompensated heart failure. All these things, although originated not due to infection, still have sepsis mimic presentations. So there are many gastrointestinal conditions like severe acute pancreatitis. So this is very important condition because they are coming with acute abdomen, and most often many in critical care units and emergency units, they think that is due to intra-abdominal sepsis. Severe bowel ischemia, fulminant hepatitis, all these things can present with symptoms similar to sepsis, but actually they are not due to sepsis. Then again, endocrine and metabolic emergencies, thyroid storm, adrenal crisis, diabetic ketoacidosis, neurological conditions at subarachnoid hemorrhages, large stroke, status epilepticus, and other critical conditions, especially major trauma and burns. Again, major trauma and burns are very important because they share same signs and symptoms of sepsis. Again, the inflammatory marker that we use to diagnose bacterial sepsis, or most people think that it can be used to identify bacterial sepsis, procalcitonin, can be high in these conditions. Therefore, we have to be very careful when we are managing, diagnosing, or getting information regarding these conditions. Then drug overdose, serotonin syndrome or neuroleptic malignant syndrome, malignancy-related syndromes such as tumor lysis syndrome, blood group incompatibility, and organ rejection in transplant. All these things can have sepsis mimic conditions. They can be considered as sepsis mimic conditions. So therefore, you have to always think that it is not sepsis, but sometimes you can get many other conditions which may present similar to sepsis. These mimic conditions lead to diagnostic uncertainty. So we are uncertain whether this is sepsis or something else. So the critical care dilemma of the critical care physicians. How to differentiate sepsis from sterile inflammation is a very difficult task, at least in the early stages. Diagnostic uncertainty frequently causes severe sterile inflammation to be misdiagnosed as sepsis. So don't believe me. If you ask senior emergency and critical care physicians, so they will tell many examples where there had been some problem with misdiagnosis of severe sterile inflammation as sepsis. And it is a patient safety issue. This common error can lead to catastrophic outcomes by delaying correct therapy. So it is a patient safety issue where all practitioners should keep in their mind. So this mistake, so you can make at any time. Diagnostic uncertainty. When you have diagnostic uncertainty, it fuels wrong decisions. When you're uncertain, it is very difficult to take rational decisions. So therefore, every time you have to think, am I correct? Am I dealing with only sepsis? Or am I missing a case of severe inflammation? Or am I missing a case of severe inflammation thinking that that is due to sepsis? So that part need to be kept in mind always. Although severe inflammation is a rare condition when you compare it with sepsis, always you have to keep in mind, especially because the patient is presenting with acute condition and you won't be able to get laboratory input till some time. Therefore, always think the possibility. So this framework is devised to face this uncertainty. This framework uses risk-stratified approach to resolve diagnostic uncertainty and prevent catastrophic outcomes. So this framework, the reference is given, and it has two axes, the y-axis and x-axis. The y-axis, we marked the illness severity. So at a lower level, low illness severity, and at higher levels, you get critical and life-threatening condition. This is marked in the y-axis. And x-axis is the likelihood of bacterial infection. As you go from left to right, the chances of bacterial infection, chances of this being due to bacterial infection become high. So when, as in Surviving Sepsis Campaign guideline, when the patient is in very critical condition with life-threatening shock, lactic acidosis, altered mentation, and respiratory failure, there is no time. You have to consider that the patient is having septic shock and initiate empiric antibiotic in adequate doses within 1 hour. So this is very well mentioned in Surviving Sepsis Campaign guideline. If the patient is not in shock, and if you still think that the patient is in sepsis, so you have 3 hours. Within 3 hours, you have to start antibiotic. And if the patients are not critically ill, and if there is evidence to say that there's infectious etiology is involved, so you have time to elucidate the etiological agent and start appropriate treatment. And you need not to rush antibiotic in this group of patients. And the other group of patients, so they are not critically ill, so they are ill but not critically ill, still you have time to find out whether there is any other alternative cause for the patient's condition. And if you can exclude infections, you can omit antibiotics, and that is something that recommended in antibiotic stewardship programs. Based on the clinical presentations and according to this framework, 4 groups of patients are present. So there are 2 groups of patients, A and B. So they are critically ill. Group B is critically ill patient who are likely to have bacterial infections. Group A is critically ill patients. Although they are critically ill, the infection is not due to sepsis, maybe some other condition, like in sepsis mimic condition. And group C is again, they are not so critically ill, but they are ill, so they are not likely to be due to sepsis. And group D is infectious and not severely ill, and you have time to act. A and B, because of they are critically ill, you have to consider giving antibiotics and providing adequate level of care to the patient in the emergency department early. So how are we going to navigate the diagnostic uncertainty with this framework? So how are we going to embark on initial patient management based on this appropriate? You can see the framework, critically ill patient, but there we have a clearer alternative diagnosis, and this group, they are critically ill with strong signs of infection. So if the patient is in B category, you can give empiric antibiotic. If the patient is in group A category, you can manage using appropriate other methods without giving antibiotics. Unfortunately, because severe inflammation and sepsis both share similar sort of symptoms, you won't be able to differentiate A from B, at least in the initial stage, without the input of the laboratory. So therefore, both A and B considered to be due to sepsis, and you have to take actions and try to elucidate etiological agents as soon as possible. In contrasting to A and B, C and D, they are not critically ill, so therefore you need not to rush to start antibiotic. You can get the information from the lab, about the etiological agent, and if a bacterial or any other pathogenic involvement is confirmed, you can give antimicrobials. And if you can exclude the etiology of infection, you need not to start antibiotics, and you can start other appropriate other non-antibiotic treatment modality based on their etiology. The problem comes when a patient presents to a critical care unit with A or B. This describes a framework for action guided by the principles of diagnostic stewardship. So this which part of this framework your patient falls in has to be decided based on the inputs from the laboratory, diagnostic laboratory. So it is very important to frequently communicate with laboratory regarding patients like this, because the input from laboratory will help to rationalize your care in the emergency department. In the severely ill, immediate broad-spectrum antibiotics are mandated by the high risk of mortality, even when infection is unconfirmed. So this is the beauty of the framework. Even the patient is in group A or group B, because of the fact that patient's life can be harmed with your decision, always broad-spectrum antibiotics are recommended. But at the moment where you diagnose non-infectious etiology, you have to stop empiric antimicrobial therapy and initiate the appropriate care for the inflammatory condition, forgetting about the antimicrobials. And it is part of antimicrobial stewardship program. So now for the summary. Sepsis is often mimicked by non-infectious conditions, creating a significant diagnostic dilemma in critical care. So the critical care units always have to keep in mind that you can come across patients with sepsis, come across patients with severe sterile inflammation. Always keep that in mind. This mimicry is not random. So this is not random. It is due to shared biological pathways where both infections and sterile inflammation shares. So that is very important to note that because the symptoms of sepsis and sterile inflammation is due to shared common pathways, especially the downstream immune mediators and the cells. Both sepsis and severe sterile inflammation shares these pathways, therefore symptoms may be same. While diagnostic uncertainty is unavoidable, it can be managed effectively with a structured risk stratified framework, the framework that we have used. The strategy is the essence of diagnostic stewardship, which aims to balance prompt interventions with avoidance of unnecessary treatments. It will help you to prevent overuse of antimicrobials as well as underutilization of antimicrobials and rationalize your therapy. So that is one of the important things in critical care management. So thank you very much. And I once again thank you, the Indian Sepsis Alliance, for giving us this opportunity to share our views on this World Sepsis Day commemorating program. Thank you very much.
Thank you. Thank you, Dr. Mahan. It was a very, very comprehensive talk. Generally, we just briefly touched based on this important topic, but you covered it in very detail. And you gave us a wonderful framework to work upon to include or exclude diagnosis of sepsis with certainty. Because of shortage of time, we'll move on to the panel discussion straight away. I'm privileged to have three panelists. Dr. Neeraj Tyagi, he is a consultant at Sir Gangaram Hospital, a very dear friend of mine. And we are running Indian Sepsis Forum together for years. We are joined by Dr. Despoina Colenti, my dear friend from UK. She is a consultant critical care at the prestigious King's College Hospital Foundation Trust, London. Welcome, Despoina. And we also have Dr. Ashwini. Dr. Ashwini Kumar is the research fellow at Sepsis Australia. He is leading many of the APSA sepsis programs and research wing, and he works for the George Institute for Global Health at Sydney. They have offices in London and Delhi also. So we must meet sometime again. And Ashwini and Neeraj both are from UCMS, for your knowledge. Okay. We'll move on to the panel discussion. We understand by various talks the time is essence in sepsis, and the time to diagnostic certainty is also important. We need to spot sepsis early. We need to stop sepsis. Then only we can save lives. So early suspicion and timely confirmation and timely right treatment options, everything is important. That is why we talk about MAP sepsis, microbiological, anatomical, and the physiological diagnosis of sepsis. So the first part of my discussion will be to Dr. Despoina. What will be the microbiological work of for a sepsis patient who is critically ill? One, you do the workup for a patient who is relatively stable, cultures will take some time. How different you will be acting for a patient who is in sepsis with shock? What are your priorities in investigating such a patient microbiologically?
Thank you for the question. When we have a patient in septic shock, time is critical, the clock is ticking, and if it is possible to move forward fast with the cultures, and I will explain what type of cultures, we will do it before the initiation of the antibiotics, but it is if the cultures delay, I won't delay antibiotic administration to take the cultures. So septic shock, as with surviving sepsis campaign, it is highlighted, we need within 1 hour from suspicion the antibiotics, the correct appropriate antibiotics to be in the patient, not prescribed, and to be given in such a dosing that we reach the concentration, the exposures that we want at the site of infection within this hour. So classic, it is the blood cultures. If we have suspicion for respiratory infection, respiratory cultures, urinary cultures. If we have CNS infection, we might need lumbar puncture, but for conventional and rapid if we have. But my emphasis is that this will not delay the administration of antibiotics. And antibiotics, antivirals, depending, because antifungals, it's not only bacteria that can cause sepsis. But this is my message. We take the cultures as fast as possible, and we don't delay initiation of treatment. In ICU or emergency department, we learn to work in parallel. We don't have the time luxury. And important, and I emphasize, especially to our more junior colleagues, it's not just to prescribe antibiotic, to confirm that the antibiotic is given in a timely manner.
Thank you, Desperna. The problem is India is even bigger, and probably Greece, Desperna, again, you have the same problem. We have a huge problem of antimicrobial resistance, especially for the gram-negative organisms. And the bigger problem is we have coexistent mechanisms of resistance in India, as was beautifully explained by Dr. Subha also. The burden is huge. When we started our practice, Neeraj and me, early 2000, the carbapenem resistance was unheard of. We just started using carbapenems. And within 5 years, the resistance was 8 to 10%. And every 5 years, the resistance is growing 2 to 3 times. For the ICU isolates now, the resistance to carbapenem is of the tune of 40, 50, 60%. So we are having a bigger challenge. So my next question will be to Dr. Neeraj. What will be your multimodal diagnostic approach for a patient who has been transferred from some other unit, or where you think there could be a resistant mechanism?
Okay, excellent question. So I think knowing the cohort of patients, that one is important. For example, when Dr. Subha was presenting her slide, she said her transplant recipients are from other countries. And probably when they're from other countries, we can assume their exposure to antibiotics is going to be much less. While in my case, most of the transfers that I get in my ICU are actually not from primary or secondary care centers, even from tertiary care centers. And typically speaking, they have been exposed already to antibiotics, which are broad spectrum, and in most situations for even more than 48 hours. So we need to have twofold kind of things. Well, first is to define what appropriate anti-infectives are going on in them. And second, if there is a scope to immediately customize them or individualize them as to what my patient needs. So first thing would be to probably identify the source of sepsis and then go for that source-specific diagnostic investigations. For example, when they come to us, they are probably, let's talk about the respiratory system infections, they are no longer having upper respiratory tract infections. So sending a respiratory panel becomes of no use or no sense. Rather than sending a pneumonia panel is what we are practicing in my ICU. Similarly, blood culture PCR panels, multiplex PCR panels, if we are deciding, they have to be based on the system diagnosis. Just previously spoken, what the Sponia was saying. So probably if I'm getting a patient after 48 hours, it's a reasonable chances I've defined whether it's a CNS infection or respiratory tract infection. Going for in such situations for a CNS meningitis pulmonaris parva important rather than basing my diagnosis on culture reports, especially if they've been exposed to antibiotics. So this is where probably we need to tweak as per the cohort of patient that we are getting. honestly speaking, are we not sending cultures in patients who are exposed to antibiotics? We do send all the cultures for a simple thing. Just recently, we had a patient who has come to us from a different state altogether, was on antibiotics for a good 7 days. We sent the cultures and then we sent the BCID panel as well. The moment it was flagged gram negative, and they said the BCID is negative. Immediately, it rang bells to us. Are we dealing with melioidosis? And fortunately, we were able to isolate melioidosis in that patient. So it's just a complex phenomena, but my message would be probably titrate as per the patient you are getting. Try to look more into the organ, and then specific PCRs is what you need to have. If we do not have people who are adequately trained, taking the help of microbiology on ID is what I also recommend lately. So this is my answer to you.
Thank you, Neeraj. So we need to detect fast and act even faster. We talk about multimodal diagnostic approach. We understand cultures are gold standard, they are needed for susceptibility, and we cannot replace cultures, the conventional microbiology, with the molecular microbiology. They are there to complement each other. But molecular and point of care tests like CARBA, RSA, they are coming up in a big way so that we can screen them in the emergency or in the ICU, then cohort them or start our next line of treatment, which covers carbapenem resistance. Third and more important, what we need to understand, and we are not talking much about it in our circles, is resistance profiling. Now we are in an era of precision medicine. And if we want to randomly cover for carbapenem resistance in India, it's a very, very difficult task. We are in dark totally. So we need to do some sort of resistance profiling. We do. We risk stratify our patients objectively on based on some other criterias. We risk stratify each and every patient. We look at the cultures and the antibiogram, MICs, and there are some resistance panels also, gene panels also for CRE, MRSA, and some other gene resistance patterns which could be diagnosed. I'll move on to the next question to Dr. Ashwini. He has done a lot of work in CRE. So my question to Dr. Ashwini will be, which patient profiles you think would be most vulnerable to develop sepsis, sepsis-related complication and mortality, and they are candidates for active surveillance for MDRO? Yeah.
Thanks, Dr. Yash. So in my experience, both as a researcher and as a clinician, the population groups which are really vulnerable are, extremes of ages, like, the both, the neonates as well as the elderly population. And also, patients with complex health conditions, comorbid conditions, especially diabetes, they are especially vulnerable of having sepsis. Then, if patient has, poor immune system, then, that should ring bell that this, patient can have sepsis either due to an underlying medical condition or use of immunosuppressive drugs such as cancer. Then patients with burn injury wounds, they are again more vulnerable to having sepsis. And again, my in my research work, what has been noted that previous history of sepsis, again, if patient had sepsis previously, that again should ring a bell that this patient, can or might have sepsis. And in terms of, the active surveillance, I think, and I, work obviously in Australia, but, what I can say is it is very important to, have a local pathogen, profiling and take your decision based on that. And I'm not sure, how actively, the ID physicians are consulted, in other countries, but in Australia, that is the standard practice where ID physicians are, consulted, and then, the antimicrobials are tailored accordingly.
Yeah. Thank you, Dr. Ashwini, for a very lucid presentation, lucid answer. So we have to diagnose MDRO early. We need to have a multimodal approach for that. We understand phenotypic DST is the gold standard for MICs and guiding the definitive therapy, but there are delays, especially for high risk category of patients such as immunosuppressed patients in septic shock, transplant patient. This time is very, very important. So we must be using molecular assays for early triage and for escalation or de-escalation, followed by phenotypic confirmation for fine tuning. So we must take the cultures and molecular techniques together instead of following one pathway. Dr. Despina, I'll move on to you now again. Surveillance PCR for MDROs. Which subset of patients will be doing surveillance and what techniques do you use and which site you take the swabs or cultures for?
Could you please repeat?
Yeah.
Because it was a bad sound.
Yeah, surveillance for MDROs, especially in the emergencies or when we transfer from some other hospital. How do you do your surveillance for these organisms, MDRO?
I won't reply how we are doing in this hospital because it depends on the hospital.
Yeah.
Based on the risk factors, as Dr. Aswani has mentioned, needs to be the surveillance. And surveillance, there is a lot of discussion if it should be surveillance for everybody or targeted surveillance. Depends on the endemicity and depends on, as you said, if the patient that is coming from another hospital or from the community as well has risk factors. Does the patient tick the boxes? It should be very well structured. Who is getting surveillance cultures, and based on the risk factors, to choose the patients that are going to be have surveillance. It's very important with the new fast test that we have now, because we can identify patients that carry MDROs faster, and this enables infection prevention control measure to be applied earlier, cohorting or isolation to be earlier. When we apply surveillance measure depends on the setting. It is very important, but in order to be cost effective, it should be tailored to the setting.
Very rightly said. So we must be having stewardship in the diagnostics also, and we must be individualizing that test. We should not be screening each and every patient. We should not be doing surveillance for carbapenem resistance or for MRSA for each and every patient. We must risk stratify them objectively or subjectively, then only choose our test wisely. In practice, what we do at times, especially for patients who have been transferred from some other centers, we do routine injector or nasal swabs or at times stool samples. And then we do weekly for high-risk immunocompromised patients. We generally use molecular platform like Expert Carba, RSA or MRSA. Or for oncology setup, we use VRE assays also. Dr. Shubha, what is your practice for surveillance PCR for MDROs?
Hello, sir. Yeah.
Hi.
Right now, we do only like CRE for the, transplant patients, and MRSA screening we would do on request. Right now, only conventional from orthopedic and cardiac units. And again, they would take a call on the deserving patient also. We have not made it mandatory. Given the point that the rate of MRSA in our setup that we have seen in the past few years is also very minimal. And at times there are units which who would go ahead with the decolonization strategy default when it comes to MRSA. So active screening at this point of time is only for CRE. We have started to give a thought on VRE screening for our own transplant patients. and look forward to that because of late with the high-end antimicrobial use for gram negatives being high, we are starting to see few Enterococcus faecium coming up as VRE in few of infections that we are encountering. So to be more at hand preparedness for these post-transplant recipients in the need, I think VRE screening is just thought of in the pipeline from our side.
Thank you. Thank you. Thanks for elucidating on that. Dr. Despina, I will move on to the next question. We have the culture sensitivity with us, and you have some MICs. How well you will choose the antibiotic and the dosage based on the PKPD and the MIC levels?
MIC levels are important, but have weaknesses as well. When we don't have a MIC and we do the empirical treatment in the beginning before we have the MIC, we can take the epidemiological cutoffs. But let's say we have the result. We can have the results of the MIC, but because the MIC can be, due to weakness of the technique, can be 2 dilution up or 2 dilution down. For the PKPD calculation, when we have a MIC that is higher than the cutoff, it is better for the PKPD calculation to go 1 or 2 MIC dilution up to make the calculation. Also, we need to take into consideration about MIC. They are it depends. We say the MIC in the blood, and for some antibiotics, MIC in the focus of infection may be differently. Let's say we have an acidic environment. It's not the 7.4, but it's much lower. Antibiotics like aminoglycosides, for example, have much higher real MIC in such environments, for example. While beta-lactams are not affected from acidic pH. We have such differences in the site of infection for, let's say, the production of mucin and the surfactant may affect some antibiotics, and also hypoxia may affect. So when we decide the dosing, we should take everything into consideration. Also, we need to take into consideration that the inoculum effect. Inoculum affects how active they are, the antibiotics, and higher inoculum may need to go for higher PKPD targets. And this is more important. The inoculum affects more at the time concentration antibiotics compared to the concentration dependent. In summary, it's not two things. It's the patient to take into consideration the changes that, let's say, a critically septic patient have, the pathogen with the MIC, and the bug. It's a triangle, the interaction, and we should take all of this into consideration. Do know our antibiotics PKPD and adjust the dosing accordingly. Do we know how we dose the concentrated dependent ones, how we're going to dose the time dependent ones. If we have suspicion for higher MIC, for example, for beta-lactams, we might need to give higher doses. We have a wide therapeutic index for them, or go for extended infusions. So there are several factors that we should take into consideration apart from bug antibiotic in order to set our targets and decide what we're going to give and how we're going to give it.
Thank you, Dr. Despina. My next question will be to Dr. Ashwini. Being at George Institute, you must be looking at health economics also. And we understand, although we talk about the cost of diagnostics, but the cost of delayed antibiotics and inadequate antibiotics is even higher, and it can cost life also. So what can be the clinical and economical consequences if sepsis is not prevented? or detected in time or treated in time. I'd like you to elaborate on investigations, the molecular techniques, the PCR-based techniques with a faster turnaround time. How can they be helpful in health economics of our sepsis patients?
Yeah, sure, Dr. Yash. So as we all know and have been mentioned few times already that sepsis is a time critical condition, and clock is ticking and every hour counts. So it is obviously of utmost importance that we diagnose sepsis, and having a faster turnaround time is crucial because uh, uh, in terms of its health, the societal impact, just to give some numbers. Uh, in Australia, it cost about $4.7 billion. uh, Roughly, see similar cost in Japan, in according to 2017 study. And in the India, the data I have is a bit older, but in 2008, sepsis costed around 53 million US dollar. And likewise in US, obviously, it tops the chart with close to 40 billion US dollar, which every year, which sepsis cause. And uh, in terms of sepsis related death, and we know that if we don't act early, the mortality in sepsis is very high. And uh, I would, urge everyone to, visit, there is a very real good data set produced by the Global Burden of Disease. It's called Microbe, and which has country-wise list of, sepsis-related death. And, and this database has now at the 2021 data set, and according to that, the global sepsis related deaths are now to the tunes of 22 million, which is more than double which was published by the the very well read the Rudd paper published in Lancet. So uh, I guess you know the faster turnaround time is important on two counts. We want to, one, establish the diagnosis of sepsis, but also equally important, as Dr. Mahin mentioned, that we want to exclude diagnosis sepsis. And because if the inappropriate use of antimicrobial agents obviously has led to the another equally big problem, which is antimicrobial resistance, and that has equally devastating impact both on healthcare and the economic impact globally. So uh, what is needed is that balance, that and I always say this, that we often highlight the need of administration of antibiotic or antimicrobial agents in sepsis, but focus should be on administration of right antibiotic or right antimicrobial agent, and in right doses, which Despon, also mentioned that, if we are not giving in right, in suboptimal dose, it won't have clinical efficacy, and it would obviously led to microbial resistance. So and that's why having these point of care modalities are of real importance, because they can inform us in a timely manner, and uh, and and not just about their pathogen profile or their resistance profile, but also the point of care, the lactate which is being used very now commonly in Australia and other countries, which really helps in diagnosis as well as prognostication of sepsis patients.
Thank you, Dr. Ashwini. So, timely diagnosis, especially the microbiological diagnosis, why is it important? We have emphasized enough, but I'll still emphasize the single most important factor for good sepsis outcome is clearance of the pathogen. So, what molecular diagnostic brings? it brings diagnosis within hours, whereas the conventional takes days. And we all understand that hours saves lives in sepsis. To give you a context, the conventional drug sensitivity, if you want to diagnose carbapenem is producer organism, it will be 48 to 72 hours at least. Whereas carbap RPCR, you can get the results within an hour and it will tell you what mechanism. And if you know the mechanism, you can choose wisely. Otherwise, you are offering a very, very broad-based therapy. You are giving ceftazidime every time, you are giving estronam, at times you are adding colistin and tigecycline. It's like the whole kitchen sink you are throwing at the patient. So we need to be precise and individualized. Although we are not suggesting to use this in each and every patient, but the right subset of patients we should be using. Same for respiratory panel and suspected pneumonias. For last 7 to 8 years, the incidence of viral pneumonia has increased manifold, and we now understand that viral sepsis is a distinct entity, and secondary infections do occur in viral pneumonia. So, Cepheid expert flu, RSV, or SARS-CoV-2, again, it will be giving the results within 45 minutes, whereas conventional viral PCR panel can take some time. Same is for the MRSA expert assay. Again, the result will be available within hours. So we should be targeting and faster diagnostics to treat our patients better. We move on to the next question. I like to invite Dr. Mahen. Are you around? If you are not driving, then
I'm listening. Yes, I'm there.
perfect.
Yes.
Perfect. So, Dr. Mahen, you are working at the National Hospital. I was lucky to visit your hospital many years back. What is your take on CRO diagnostics and CRO screening for transplant patients, specifically for liver transplant and HSCT patient?
Yeah, actually, we don't do hematopoietic stem cell transplant. So we do occasional liver transplant. So we don't have a separate carbapenem resistant organism screening process. But what we go by the degree of MIC. So now, if the MIC of carbapenem, if I remember correctly, it's around 4. And if it is going high around more than 16 or 32 level, we assume that that is due to KPC. But anyway, the rates are very much less when you compare it with other parts of the world in our region. So basically, we go by the meropenem resistance and the MIC, the degree of MIC. If it is higher, we consider it as due to carbapenemase, and the only option that we are having is colistin. And if it is within the range, it can be OXA or efflux pump or something like that.
Thank you, Dr. Mahen. And thanks for the wonderful talk. It was one of the most comprehensive talk on sepsis mimic. We'll move on to the next.
Thank you very much.
Thank you. Thank you, Dr. Mahen. I'll move on to the next question. You must be wondering why we are talking about carbapenem resistance and hammering, because the resistance what we see in India is huge. 40 to 70% of our isolates in ICU are carbapenem resistance. That is why we are trying to emphasize more and more about it. Dr. Neeraj, as a busy intensivist and as a tertiary level ICU, we also have a lot of carbapenem resistance. And NDM incidentally was discovered at your institute. So how do you optimize antibiotics based on carba RSA?
So, I mean, it's like what we do for all these tests. We use patient condition and we also use the pre-test probability of this turning positive or negative. For example, if my patient is having any kind of risk factors, I mean, we have been discussing a lot about liver patients. So, patients who have been decompensated chronic liver disease, patients who have had a recent episode of spontaneous bacterial peritonitis, we understand they have been exposed to various kind of oral and even IV antibiotics. Then the range can be BL-BLI combination to even third generation cephalosporins. So this is a subset of patient in which we are really using most of this in addition to primary blood culture techniques. So for example, if the carb is positive for a carbapenemase gene and my patient is unstable or septic, the whole idea is to escalate the empirical therapy. The moment carb is back with what kind of CRE we are dealing with. We do not get so many KPCs. We get either OXA 48, as Dr. Subba said, as same is the situation in my institute. and OXA48 plus minus NDM, OXA48 plus minus ESPL. And depending on the combinations that we have, for example, OXA48 with NDM, then obviously the choice becomes ceftazidime avibactam plus estrionam. But if you have a OXA48 and you have a ESPL combination, ceftazidime avibactam alone is going to be enough for us. And if it's like not OXA48 only NDM is positive, then of course you can titrate for estrionam based kind of therapies as well.
Thank you, Doc. Yeah.
Second situation is probably when CARB-R is negative, and we also had clinical suspicion for CRE pretty low. So of course we can de-escalate from carbapinams very, very quickly. You asked Ashwin about health economics, and to me, this question brings maximum into health economics. If we are able to reduce the amount of antibiotics given, both as a combination therapy as well the duration of therapy, to me it perfectly fits into the gamut of optimizing our economics for individualized patients as well.
Yeah. We are in a gram-negative world in India, but that's when I think you see a lot more of resistance in gram-positive MRSA and VRE. How do you apply these molecular diagnostics and PCR, especially MRSA, assay, and VRE, in your clinical practice? Before that, the incidence of MRSA was huge in US long back, mid 70s and 80s, and they started screening for MRSA. Then they could control the MRSA. What is your practice in UK?
Okay, the practice is not the same in all hospitals. In my hospital, we don't have a lot of MRSA, I would say, and they would do MRSA screening when they are entering the ICU.
Okay.
Not with rapid, if at the best of my understanding, and they also test for VRE. But I have a lot of experience from gram-negative as well, because I have worked a lot of years in my country, in Greece, that we have a similar problem, and it's the only country from Europe that we have the same color as India. If you see with the CRE, we have problems also with Acinetobacter, we have problems with Pseudomonas, etc. So I think it's a must to say and corroborate what Dr. Niraj said. It is, I think the huge problem is with gram-negative pathogens. Before I was explained about the surveillance, I emphasize that I'm not talking about my hospital, but about how I think we should do not universal surveillance, but targeted. If I specifically in my hospital, they do CPO screening as well. Yeah. For the ICU, not for everything. But this is not the whole practice.
Yeah.
So I think, as I told you, we don't have a lot of MRSA in my hospital, but in centers, in settings that they have a high MRSA prevalence, it's very important to have the rapid test, to have the MRSA result fast and do the isolation and the cohorting. And also, if a patient comes with a high risk factor for be colonized with MRSA, let's say end-stage renal failure, that they are in a dialysis clinic, or a previous MRSA colonization, etc. So it is very important, depending on the setting, to have also the fast results of MRSA or VRE colonization. I would like to mention something. We say about the fast test and that we identify the mechanism of resistance. It is super important because now we know we have a lot of antimicrobials that target specific mechanisms of resistance that we are likely to find with a test. But we should not forget, as it was mentioned also from Dr. Suba, that we have other mechanisms of resistance, especially for Pseudomonas, that we cannot capture with the test. The protein efflux pumps, the changes of the OPRD, several other, and we should bear that in mind if we don't find the resistant mechanism, but we have suspicion. And also, I think we need to find strategies how to deal when we don't have viable pathogen gram-negative identified, and we identify the mechanism of resistance. Should we treat? How we gonna individualize? What should we do?
Absolutely.
And I'm bringing this up to all the panel for input.
Yeah. That is why we always invite you for discussions on antimicrobial resistance. Greece and Indian practices are almost same, and there is a saying which we talk about in our critical care circles. They are like olives in Greece; they are everywhere. So that is why your understanding of antimicrobial resistance is even better than ours. So I would like everyone to give inputs on Dr. Despina's query. If I speak on my behalf, we individualize testing. We do not do a blanket testing. We do not send routine assays for all the patients. But yes, high risk patients, patients who are critically ill, patients where we think it could be an exotic infection or difficult to isolate or culture, immunocompromised transplant patient, these patients will like to have the diagnostic uncertainty for the microbiological agent from very beginning. So this subset of patients will like to send CARBA assay or MRSA assay or a sepsis panel likewise for the site of infection like a pneumonia panel we discussed about. So we'll individualize and have diagnostic stewardship. Will not send blanket assays or blanket cultures for any of the patient. Others can comment on this, Dr. Ashwini, Dr. Neeraj, Dr. Subha. You are mute, Dr. Subha.
Just agree with you. I mean,
Yeah.
no extra points.
Dr. Neeraj, Dr. Ashwini, Dr. Mahen, anything different?
Also, probably the same thing. So
Yeah.
first thing is to risk stratify my patient, whether it's likely to have CRE, or in certain situations, we do screen for MRSA as well. And VRE, as Dr. Subha is pointing out, is something what we have realized. Somebody who has been exposed to second and third generation cephalosporin without BLIs, that's where the incidence of VRE is coming up pretty high after a period of 2 or 3 weeks of antibiotic therapies. So not for everyone, of course, it's not a blanket thing. If patient is clinically really unstable, and when I mean clinically unstable, it's primarily either hemodynamic instability or respiratory therapy, which is needing FiO 2.6 and above, when we're thinking of in terms of probably respiratory tract infection. They are the ones in which we send more of these diagnostic profiles, because the disease is probably due to a high virulent organism, or patient is in precarious situations. Second would be, as Dr. Ish already said, those patients who are either immunocompromised or have been exposed to antibiotics repeatedly. So this is about us, not for everyone, for sure.
Other question regarding this panel discussion or the talks before this? Any questions from the audience? Ritu, Mr. Varun. Any other comments or questions from the audience?
No, sir, there were no questions.
Mr. Varun, any questions? I will summarize then.
Yeah, please go ahead and summarize. I don't see any questions.
Then you can probably give the vote of thanks.
Dr. Yash, before you summarize, can I say something?
Please.
I would like to say that I totally agree. I think Dr. Neeraj has said that it's an algorithm, how we're going to use this test. And the algorithm is different depending on the baseline of each sender. And we need to tailor our algorithms to our surveillance data. And this algorithm may change during the time as our pathogens are changed, our resistance are changes, because depending on the baseline, the same test can have different negative or positive predictive value. So our test should be in specific, tailored to our unit algorithm, and also within a more general antimicrobial stewardship program. I totally agree with what it was said.
And we must focus on infection control, as was highlighted. We always talk about infection management and forget infection control. Or we must utilize these molecular techniques for early initiation of infection control. Most of the time, we cohort them or isolate them very, very late. So we must start the practices early. So summarizing the discussions from today, we started from MAP sepsis, microbiology, who is the enemy, anatomy, where is the enemy, and physiology, what is the damage. We moved on towards the resistance patterns. We moved on towards the CRE. We talked about sepsis mimics. We talked about good practices from Dr. Ratnam, which were very, very useful and helpful in day-to-day practice. And the sepsis mimic talk from Dr. Mahin was eye-opening. Dr. Shubha highlighted not only on infection management, but also on infection control aspects. And the last part was about diagnostic stewardship. We must follow diagnostic stewardship, right test for the right subset of patient. Cultures remain essential for susceptibility testing. Molecular techniques and these CARBA-R or MRSA assays are complementing the conventional microbiology techniques. They are not going to replace them. Resistance profiling is what we should be doing. Firstly, objectively or subjectively. Second thing, based on cultures, then PCR or assays, whatever point of care testing we want to use. I like to thank each one of you, Dr. Terespiona, Dr. Subha, Dr. Mahen, Dr. Neeraj, Dr. Ashwani, Ritu, Asya, and Dr. Ratpum for brilliant inputs. And to increase our collective intelligence, I like to hand over to Mr. Varun Suneja for vote of thanks from CEFIT.
Thank you so much, Dr. Javeri, and thanks a lot, everyone, for attending today's session. It's been a pleasure, I think, learning about sepsis, and I think we tried to squeeze it in the month of September itself, today being the last day of Sepsis Awareness Month. So yeah, I think at CEFIT, we are committed to providing, diagnostic solutions, the molecular diagnostics, which are really, helping, do a different way for the patients, especially for early diagnosis and management of sepsis patients. And yes, we do have solutions which are in the broader AMR portfolio as well, which can really help serve your patients better. So thanks a lot, everyone, for all your time today. It's been an exciting discussion and really some great insights which flowed across everyone. And yeah, we look forward to keep in touch with you, and we look forward to your inputs as well. I think there's a link which has been shared in the chat. So please do share your feedback on how the webinar went and what topics would you like to hear in the future as well. So thanks again for all the collaboration, APSA and ISF, and all the faculty members which we have today. Thank you so much.
Thank you. Thank you, everyone.
Can I say
yes, please. Yes, please.
We have been, as you just said, we have been reading most of the chapters and researches which is coming from Greece about the challenges and how you guys have been getting antibiotics and how you have been using it. But to me, it was also an eye-opener to interact with you, Desponia, in person. But the other thing is like what Ashwani, Mohan, and Ratupan brought about how the practices are happening in their countries, how they're customizing the guidelines. To me, that's very stimulating for us. And of course, Dr. Subha, we have been reading your work about liver transplant, other things. So personally speaking, it was great sharing experience. And to me, we all must thank Yash. He has been coordinating with all of us since a month's time, and the kind of questionnaire he prepared, it was excellent. So great, Yash, and of course,
thanks a lot.
Your team. I enjoyed it thoroughly. Thank you so much.
Thank you, Dasprona, Dr. Subha, Dr. Ashwani.
Thank you, everyone.
So much, everyone.
Bye-bye. Thank you, Dr. Mahen. But don't switch on the video. Don't switch on the video while driving. Be safe.
Right.
Congratulations, and again, it has been an honor and a pleasure to be in this panel with all of you. Hope to see you again.
But we'd like to see you in person soon. This year again, we are missing you. Probably next year we must meet. Thank you, everyone.
Thank you very much.
Thank you.
Bye. Have a good day. Have a good day. Bye-bye.
Thank you, everyone. It was a wonderful and very informative session. Thank you all for joining and for giving us the opportunity to host the session. We hope to have you all again on our platform very soon. Thank you very much for your time.
Bye-bye.